Pretty much right on time, I hope. Provosts, guests and colleagues, you're all very welcome. And my name is Brian O'Connell, Dean of Health Sciences, and thank you for coming this evening, especially on such a fine day. You had stiff competition there, Andrew, with the weather. So it's my great pleasure to introduce Professor Andrew Davies, who will shortly be giving his inaugural lecture, an honour given to full professors in the university. In 2021, Andrew was appointed consultant and professor of palliative medicine stationed at Our Lady's Hospice and Care Services in Harold's Cross, which is also affiliated with UCD. Andrew has accomplished a great deal in such a short time, especially since you could say he had a standing start. Yes, if you remember, January 2021 were the dark days of COVID, with vaccines just beginning to appear, when Andrew came from Britain to take up his position here. With little previous experience of Dublin, he spent the first 3 weeks in the Shelburne Hotel, showing, I should say, very good taste, though maybe setting the bar a little bit high for future staff. Provost, please take note. While getting straight to work clinically, it was some time before Andrew was able to really meet with all of his colleagues. And despite this, he has injected momentum into the discipline, having over 20 years experience of clinical care, research and education. As his colleagues said to me, Andrew is a researcher through and through. Where some see puzzles, he sees studies. Where some hold opinions, Andrew quotes facts. He's difficult to argue with because he's invariably better informed and, even worse, very often correct. Note often, not always, but he's comfortable questioning the status quo and has brought lots of new ideas. I think that's a great tribute. Andrew Davies is, of course, a recognized and respected leader in palliative medicine, truly grounded in clinical care. Before coming to Dublin, he was clinical lead for supportive and palliative care and consultant in palliative medicine at the Royal Surrey County Hospital and St. Luke's Cancer Centre in Guildford, having filled a number of clinical and management positions of increasing responsibility over the years. Throughout his career, Andrew has also taken on numerous leadership roles in professional organizations, such as the Multinational Association for Supportive Care in Cancer, where he served as board member and recently as president. He has played key roles in the European Cancer Organization, the Royal College of Physicians, and the Association for Palliative Medicine of Great Britain and Ireland, where he also served as president, to name but a few. In addition, according to a well-informed source, Andrew has contributed significantly to the development of palliative care research on a global stage. He was a visiting reader at the School of Biosciences and Medicine at the University of Surrey, where he continued an active and productive academic career, including visiting professor at MD Anderson Cancer Centre and appointments at Imperial College, the Institute of Cancer Research, King's College and the University of Bristol. As many of you know, filling dual or even triple roles like this can be very challenging, but yet Andrew published well over 100 articles and an impressive series of books by Oxford University Press, won a substantial amount of grant funding and presented at countless conferences, including, I might add, that some I now realize I also attended, such as the International Association for Dental Research, of which I happen to be president currently. And so for Andrew, the academic, the opportunity to spend more time in research was a major reason to move to Dublin, and he is making excellent use of his time. As his co-worker told me, Andrew has demonstrated complete commitment to the integration of education and research with clinical practice. We are very fortunate to work with someone of his caliber and experience. And this brings me to the thing I like most about Andrew. He actually realizes that the mouth is part of the body, and he has devoted much of his research career investigating the oral health of patients with cancer. In fact, his MD dissertation was an investigation into the relationship between salivary gland hyperfunction, I'm swooning, and oral health problems in patients with advanced cancer. And he was at one time an honorary research fellow in oral microbiology. But Andrew not only published on many different aspects of oral health, but of course cast his considerable intellect much broader to issues of concern, such as breakthrough pain, circadian rhythms and sleep disorders, remote monitoring, and many others. He is hungry to improve the care for patients and to challenge the accepted wisdom. According to his colleagues, he does this with energy, vision, and ambition. Perhaps the only chink in his academic armor and scientific rigor is his admiration of Chelsea Football Club. Surely the sign of a man who at least partly is living off past glories. Was that another thing that attracted you to Trinity? I wonder. Takes a minute. Anyway, Professor Andrew Davies, you are very welcome officially to Trinity College, and I invite you to give your lecture, Back to the Future.
Thank you very much, Dean. Very nice introduction. A lot to live up to. I have to say, I've been worrying about this talk for a very long time, and it hasn't helped by coming to all the other inaugural lectures and listening to my esteemed colleagues and all the great things that they've done within the School of Medicine and beyond. But actually, Professor Keane, when I said that to him, he said, and I have to paraphrase this, you'll be fine, Trinity don't employ people who are TUP. Now, you might not understand, as I said, I'm paraphrasing. So TUP is the Welsh word, or a Welsh word for stupid. And as I don't think that Dean mentioned, but I am actually Welsh. And my surname is pronounced Davies, not Davies. And throughout this talk, I might slip into a bit of Welsh vernacular. So I thought what I would do right at the beginning is give you a sort of introduction to sort of some typical Welsh vocabulary. So tidy means good. Okay. Lush means very good. Okay. Chops, okay, the mouth. And I have, as the Dean has said, an interest in chops. Chopsy means very talkative. And a poppity ping means microwave. Now, I am going to bring in all of those phrases into the next 40 odd minutes, believe it or not, even poppity ping. Okay, so yeah, I feel very honored to be here. I will explain how I got here in a little while. If I can move my slides up. Okay, so I've entitled my lecture Back to the Future. Now, there are a lot of people in the audience who weren't around in 1985 when this film came out. I think some of my research staff, probably their parents weren't even around in 1985. So I'm just going to give you a little summary. This is also for my wife as well, who is much, much younger than me. Okay, and was in, I think it was nursery when this came out in 1985. So Back to the Future. So Dr. Emmett Brown, the mad scientist, develops this time machine and he puts it inside a DeLorean. And Marty McFly, who's the hero of the film, gets into the machine, is being chased by Libyan terrorists. Long story, haven't got time to tell you. And he goes back in time to 1955. And in 1955, he comes across his parents, who are teenagers, they haven't got together yet. And while he's there, he meets the old Doc Brown, who says to him, now you've got to be really careful, because anything that you do in this time period will affect the future, will affect your present. And what I'm going to talk about is some of the things that happened to me in the past that have led me to end up in Dublin, but have shaped, if you like, my practice and my philosophy, particularly around research. Okay, so let's discuss. So my name is Andrew. I am a palliative medicine consultant, physician. Okay, yes, palliative medicine. Everybody thinks they know what palliative care, palliative medicine is, but actually it's perhaps not what you, or what a lot of people think, and certainly what the general public think. So I think a lot of you probably know the parable of the blind men and the elephant. So the blind men come across this elephant. They don't know anything about elephants, and each of them end up touching a different part of the elephant and believe that they're touching something not elephant-like. Okay, and that's what palliative care is like. It's very heterogeneous. So I spent the 20 years before I came to Dublin working in cancer centres. So the majority of the patients that I saw were patients on treatment, had symptoms, maybe being cured, having curative treatment, maybe having disease modification treatment. But I mainly saw patients with symptoms due to the cancer, due to their cancer treatment. So doing essentially a lot of supportive care. We did look after dying patients. But palliative medicine has changed dramatically from the early days, and I will talk about the early days. So it's not just about end-of-life care, although we do an awful lot of end-of-life care. An end-of-life, as defined by the General Medical Council, is the last year of life. So actually, a lot of us in our day-to-day clinical practice, whatever that is, will be seeing people in the last year of life. And most people, irrespective of their disease, cancer, COPD, heart failure, will spend a lot of time during their last year in hospital. So whenever you, and I used to not tell people I worked in palliative care. I used to make up some other story. Used to say I was a cardiologist. But then people started asking me about their arrhythmias, and I thought, no, I'm going to have to start being honest. But a lot of people think that it's very sad working in palliative care, that we're all depressed, go around crying all the time. And some of us do. But actually, the thing about palliative care, palliative medicine is we're set out to try and improve people's quality of life. So for our oncology colleagues, it's about trying to cure the patient, trying to cure the cancer. Okay, and sometimes they're successful, but often they're not. And as Professor Lowry talked about in her inaugural lecture, there's been huge advances in the management of cancer, and the outcomes are much better, but still the majority of people will die of their cancer. They might not die in months as they did, say, 10, 20 years ago. It might be in years, but still the majority of patients who develop certainly metastatic cancer will die. We can generally do something about the patients we see. We can improve their symptoms, improve their quality of life. So that's why it's not depressing, because we have little wins every single day. They might not be as big as some of the, I say, successes that people like Prof. Lowry do, but we have lots of little wins. The other thing to say about palliative care, palliative medicine, is there's this perception that we're all really nice and cuddly. And most of us are. And certainly all the people, I'm looking around in the audience, all of the palliative care people in the audience that I know are really nice. I'm not sure about cuddly, but very nice. Okay, but there's also a lot of not very nice people in our specialty, because our specialty is just the same as every other specialty. The people who go into palliative medicine are just the same as the people that go into cardiology, respiratory, whatever. Okay, and some of the people that I most dislike in the world, okay, she knows who I'm talking about, are colleagues that I've worked with in the past. Anyway, and just like this person, they shall not be named. Okay, so what I want to do is, assuming I had a time machine, I want to take you back to 1994. Okay, again, a lot of people in the audience probably weren't even born then. Okay, and so back in 1994, so I finished medical school, I'd done some SHO jobs in medicine, I got my MRCP, and while I was doing that, I'd done a couple of jobs in oncology, and I really liked oncology. And so I decided after I got my MRCP, I was going to go into clinical oncology, radiation oncology. And so I got on the training scheme, the South London training scheme, which at that time was Guy's, King's, and St. Thomas's. And I did that for a couple of years, and I didn't like it. It was very different to what I'd been doing when I was an SHO in oncology. I didn't like it. I wasn't interested in it. You had to do another set of exams, the FRCR. So you had to learn a lot about pathology, about radiation biology, and those are not exciting topics. I apologize if there are any oncologists in the audience, but they are not exciting topics to learn about. And the longer I was in it, that I spent more and more time in little offices, drawing lines around tumors rather than actually seeing patients. And I decided it really wasn't for me. And so there I was, 1994, really lost. I wasn't in a good place. I didn't like my job. I didn't know what I was going to do. I even thought about leaving medicine, and the rest of my life wasn't in a particularly good place either. And then I met the person who's laughing on the left-hand side, quite by accident. And suddenly everything was great. There was this amazing woman, okay? And for whatever reason, she quite liked me. And just like overnight, from being like a mess, suddenly I was, I could do anything. And then I bumped into this lady. So this is a terrible picture. And if she saw this picture, she would go absolutely nuts. So this is something called Frances Kalman. So Frances Kalman, clinical oncologist at King's. And I don't even know how the conversation came around, because at the time I wasn't working with her, but we somehow bumped into each other, and she asked me what was going on. I told her I was unhappy. I was told that I was thinking about giving up medicine. And she said, well, why did you get into oncology in the first place? And I told her. And she said, well, have you thought about doing palliative medicine? And I hadn't, which was a bit bizarre, really, because I was working at St. Thomas's at the time. And upstairs on the top floor was the academic department of palliative medicine, the Sainsbury's academic department of palliative medicine. And leading that was a guy called Jeff Hanks. He was the first professor of palliative medicine in the UK. And his senior registrar at the time was somebody called Mari Fallon. And Mari is now the professor of palliative medicine in Edinburgh. And I'd worked, because I'd been working in clinical oncology, I'd worked with them for quite a while. But it never occurred to me, maybe that's what I wanted to do. But I thought, well, why not? Because what are the options? I could become a GP, and I really, really didn't want to become a GP. Again, apologies to anybody who's a general practitioner and really loves it. Okay, but the thought of spending the rest of my life in general practice, I would rather have gone and left medicine altogether. So I thought, well, give it a go. And, with my newfound love, and who was, filling me full of enthusiasm, I did. So I went and took a job in a place called St. Raphael's Hospice. So St. Raphael's Hospice was run by an order of Roman Catholic nuns. It's based in North Cheam. It's a very small hospice. And I was lucky enough to have a trainer called Sheila Poper. And I'll show a picture of Sheila in a minute. And she was just what I needed at the time. Somebody to take me under their wing and show me all the things that were possible within the specialty. I then moved on to St. Christopher's Hospice, which is, or was at the time, the place to go. People from all around the world would come in there to learn about specialist palliative care. And I went there. And I will talk a bit more about St. Christopher's and what I got from St. Christopher's in a little while. Then I went to King's. That was interesting. That was, it's a bit like for those of you who haven't worked at King's. So King's is in Camberwell Green. South London. It's not the leafy part of South London. It's a bit like St. James's on steroids. I used to drive to King's because we lived a long way away, and that was the only way you could get there. And frequently used to get there a bit early and used to think, well, I'll nip down to McDonald's, get a bit of breakfast for going to work. At least once a fortnight, McDonald's was shut because somebody had been stabbed in it overnight, and it was it was an interesting place to go. Then I went back to St. Christopher's, not through choice. The training committee sent me. And then I went and did research at the Royal Marsden Hospital and also King's Dental Institute, King's College Dental Institute. And I was the Sackler Research Fellow. So for those of you who don't know, the Sackler family owned Purdue, and Purdue, amongst other things, made OxyContin. So they were a very wealthy family. They're not very wealthy anymore, but I was, regularly writing. I was a Sackler Fellow, and back in the late 1998, etc. That was quite prestigious. That's now been taken off my CV. Just a research fellow. And then I finished my training, and I actually was invited to apply to be the senior lecturer in Bristol. So Jeff Hanks, I showed you before, professor of palliative medicine, moved from St. Thomas's to Bristol. And he invited me to come as a senior lecturer, which I did. I then got invited to go back to the Royal Marsden Hospital, where I'd been doing my research. And that was a really tough decision. And I'll talk a bit more about that. And stayed there for a good 7 years. And then got a bit fed up because I wasn't head of department, didn't have a lot of influence on how the department was being run. And so that's when I moved to the Royal Surrey. And I will talk about the sort of mix of clinical and academic a little bit later in the talk. So these were my two trainers when I started in palliative medicine. So the first one on the left is Sheila Popert. And does anybody recognize who she's talking to? She's talking to the Queen of England. She was just plain old Camilla in those days. And Sheila, if you ask people who work in palliative care, tell me something about Sheila Popert, nobody knows about Sheila Popert. She's one of the workhorses. She's worked in a number of different hospices. But she really set me up for a career in palliative medicine. She was quite chopsy. She let you know what she thought. And she let everybody else know on the team what she thought. And I'll come on to some of the things that she sort of pushed when I was there. The other person is Mary Baines. Now, if you ask people in palliative care about Mary Baines, they have an idea about her. She was Cecily Saunders' sidekick. She was not Cecily Saunders' sidekick. She was the woman that made St. Christopher's tick. She is the best clinician I've ever come across. So when I met Mary for the first time, this picture was probably taken not that long afterwards. Mary was in her 60s. She was getting close to retirement. She had the sharpest mind of anybody I've ever come across. She was still up to date with the literature and whatever. But she was one of those people who said, what would you do? And if you said something that wasn't the St. Christopher's way, she'd go, yeah, okay, let's do it. So these two people shaped a lot of what I've done subsequently. And working with both of them was a bit like having a toddler, okay? Because all the time it was, why? Why? So why is this patient vomited? Because they've gone into renal failure. Yeah, but why have they gone into renal failure? And what are you going to do about it? And they were very much, okay, yes, we're working in a hospice. Okay, yes, these people have got advanced disease, usually advanced cancer. Yes, their prognosis is poor, but we're terrible at prognosticating. So before we just say, oh, this patient's in renal failure, we'll not worry about it. Should we send them for an ultrasound to see if they've got, you know, an obstructive uropathy that might be easy to sort out? And they wanted me to tell them what I wanted to do. And they would go with what I wanted to do as long as I could justify it. And that's my philosophy as well. You know, I have an opinion about most things. I'm not sure my wife sitting at the front is a good idea. I think we need to put it at the back. I have an opinion about most things. And as was the Dean commented, you know, I will fight my corner, but I'm quite happy for somebody to challenge me. I'm quite happy to do other things, but you have to come up with a reason why doing what you say is better than doing what I say. Okay. I.e., what's your evidence? And sometimes there isn't evidence. In fact, a lot of the time there isn't evidence. So you're all very familiar with this, the evidence-based medicine pyramid. So in an ideal world, everything that we do would be based on systematic reviews and meta-analysis of multiple randomized controlled trials. Okay. Unfortunately, still within palliative medicine, palliative care, there are very few randomized controlled trials. And what we do, a lot of what we do is based on what was done at St. Christopher's in the late 60s, early 70s, and then subsequently was done at Michael Sobel House in Oxford, okay, in the early 70s. Okay, if it's good enough for Cecily Saunders, if it's good enough for Robert Twycross, okay, it must be good enough for us. And the problem is when you've done something for such a long time, people, and everybody's doing it, people assume that there's an evidence base to back it up. And what Sheila and Mary did for me is to say, okay, this is what most people would do. This is what it says in the textbook. But actually, we don't know. Okay, because nobody's done the research. Okay, so you have to take everything with, or a lot of things with a pinch of salt. And the other thing that they really drove home to me, particularly Mary, was, and David Sackett, when he talked about evidence-based practice, evidence-based medicine right at the beginning, it was very clear that, you know, yes, you need the evidence, but you actually have to apply that evidence to the person in front of you. So personalized care. What Mary in particular also said is you've got to take note of basic science, pharmacology, physiology. Okay. And a lot of the things that have been recommended in palliative care, they don't make pharmacological sense. Okay, so for instance, the WH ladder, the three-step analgesic ladder, okay, which has been the cornerstone of the management of cancer pain. For years and years, people in the know have been saying, this is absolute nonsense. Okay, it doesn't make sense. It's not scientific. It's not based on any evidence. But it was introduced in 1986. It was only discontinued in 2018. And actually, it is still being taught. It is still being used, despite the fact it's been discredited. I'll come back to some of these points in a minute. So they instilled in me this thing, okay, what you're being told, what people are doing, okay, is the best practice at the moment. It's based on a lot of experience, but it's not based on evidence. And actually, people like you, like me, need to go and generate that evidence, because it may be we're not doing the right thing. And one of the big innovations when I was at St. Christopher's was the use of nebulized opioids to treat breathlessness. It was in our standard textbook, the Oxford Textbook of Palliative Medicine. It was the thing that got the most column inches of interventions to manage symptomatic breathlessness. And at the time that this was written in the Oxford Textbook of Palliative Medicine, there was one case series and one other case report of the use of nebulized opioids, saying they were amazing. When the randomized controlled trial was done, well, several randomized controlled trials were done, they showed it was a complete waste of time. But practice changed because an eminent palliative medicine academic said, we should be doing this. And reiterated the fact that even though there wasn't a lot of evidence, this is what they've been doing in their unit for a long time. Okay, so I talked about St. Christopher's. And a lot of people think that, you know, palliative care, palliative medicine originated in St. Christopher's. And that Cecily Saunders, so this is a picture of Cecily around the time, late 60s, early 70s. Cecily was the driving force. And she certainly was the driving force for the change, if you like, the modernization of the specialty. But the first hospice was opened 900 years before St. Christopher's. And actually, Our Lady's Hospice, okay, was opened nearly 80 years before St. Christopher's. And Cecily Saunders trained in St. Joseph's Hospice. So there was a culture of hospice care already ingrained in certainly the UK and Ireland, and people were trying to develop that as a specialty, and Cecily took it to the next level. Now, Cecily is an amazing woman, was an amazing woman. So she started off life as a nurse, and she injured her back. So then she trained as a social worker. And while she was a social worker, she was looking after people, some specific people who were dying, and she was appalled by the lack of care, lack of support for dying patients. And so she was trying to do something about that. And she was told, listen, nobody's going to listen to you. You're a social worker. Okay, if you want to really make a difference, go and retrain as a doctor. So she went and trained as a doctor, after training as a nurse, after training as a social worker. And she was the driving force for the sort of development of the specialty. So St. Christopher's opened in 1967, and I'm going to talk a bit about their philosophy because it's really important to understand what their ethos was when they opened the hospice. And then, as you can see, palliative medicine became a specialty in 1987. So this was, you know, less than 10 years before I started training. So what was the ethos at St. Christopher's Hospice? Well, it was that research should drive clinical practice. So when they built the hospice, they built a post-mortem room in the basement. And they used to do post-mortems on patients who died of specific problems. So particularly patients with malignant bowel obstruction. What they wanted to do is understand what was going on so that they could come up with some treatment strategy. A hospice with a post-mortem room and a pathologist who used to come and do regular post-mortems. They had the most amazing medical records. When I was there, I wanted to do a retrospective case note review, and we pulled hundreds of notes. There wasn't one set of notes we couldn't find. And when somebody had died, there was an administrator who tidied up the notes. It was fantastic. So everything that Cecily wanted to do was to be evidence-based. That should drive clinical practice. And what she realized is that actually you needed experts from different fields. So she recruited experts from different fields to come and work there. And then as the sort of the message got out there, experts would then sort of congregate towards St. Christopher's. So her thing wasn't being a clinician. She was a clinician, but her thing was more about developing the specialty. She was out there promoting St. Christopher's palliative care And she needed somebody at base to sort of develop the clinical regimens, etc. So she appointed people like Mary. She appointed people like Robert Twycross. So this is Robert Twycross. He's a very famous researcher, educator within palliative care. He did a lot of studies around analgesics. He was the guy who took the Brompton cocktail and did a variety of studies to show that actually you could take the gin out of the Brompton cocktail and it was still an effective analgesic. And actually you could take the cocaine out of the Brompton cocktail and it was still an effective analgesic. And all he needed was the diamorphine. Okay. And he did studies as well, looking at the use of methadone versus diamorphine for cancer pain. So she dragged in people, okay, who could support what she wanted to do to build the evidence base. She brought in people like Colin Murray Parkes. Colin Murray Parkes, psychiatrist, he was the one who sort of helped develop a lot of our understanding about bereavement. John Hinton, another psychiatrist, again, who did a lot of research around psychological problems in patients and carers. She brought in the pain team from King's. They used to do epidurals and nerve blocks at the bedside in the hospice for those patients who were too sick to transfer to the hospice. And actually, they would do whatever it took for these patients. And a particular hobby horse of mine. So when I was there in the late 1990s, we had a patient who was in status, patient with a brain tumor, had large doses of midazolam, had phenobarbital. Okay, nothing was controlling the fits. And this was really distressing for everybody. And we didn't want to send the patient to hospital. And the patient and the family didn't want to go to hospital. The patient was unconscious at the time. So I suggested, because I'd read something in the journal, we'll try propofol, intravenous propofol. We started the intravenous propofol. We had really good links with King's. So getting the propofol was not a problem. We started the propofol, patients stopped fitting, or objectively fitting, didn't do EEGs. And this patient died subsequently a few days later. But it was a case of, right, we have a problem, how can we sort it out? Nothing was too difficult. If we have to do something that's out of our comfort zone by giving an intravenous infusion or an epidural or an intrathecal, we will do it. And that was great. And actually, St. Christopher's was this shining beacon in the 60s, late 60s, 70s, and 80s. And then something changed, and something changed in palliative care. The pioneers were getting on, were retiring. And the people coming through didn't really have the same drive as their forefathers, if that's the right word. And also there was this thing about palliative care, palliative medicine being very a Rolls-Royce service, okay? You know, 7% of people who die in the UK die in a hospice. But what about all the other people? So what we need to do is we need to take palliative care out to the masses. And unfortunately, in doing that, we had to dumb it down a bit. Okay, and then we started doing some bizarre, strange things, not doing things properly. So these are some European guidelines for management of cancer pain. And there's a series, I think it's 20 recommendations, and this is number 6. So the traditional way of managing cancer pain is you put somebody on a short-acting opioid, you titrate up the dose. When the pain is controlled, you put them on a modified release version. And there, so the recommendation in 2001 was, well, instead of waking the patient up in the middle of the night, you just give them a double dose at 10 o'clock, and that will suffice. Now, in what other scenario do you double the dose so that the effect will last for twice as long? I mean, that just goes against all everything that we learned in pharmacology. This is nonsense. And actually, if you trace back how they came up with this, the original description of this says, actually, most people, it doesn't work. But it got into the guidelines. And we did a very simple study. We actually measured people's pain scores and how many extra doses of opioids they need during the day. And actually, if you wake somebody up in the middle of the night who's not in pain, and you give them some analgesic, they go straight back to sleep. If you let them wake up in the middle of the night in pain, okay, they ring the buzzer. It's at night, okay? You need 2 nurses to, these are the old days. You need 2 nurses to dispense the opioid, okay? It takes an hour, maybe, okay? Because one nurse has gone off, okay? It takes an hour to get the analgesic. Then it takes another hour for it to kick in. So the patient's there in the middle of the night in pain for a long period of time. And we showed that that was absolute nonsense. And actually, they changed the guidelines on the basis of this. But we shouldn't have had to do this study because they shouldn't have made that recommendation in the first place. And it really went wrong in terms of the Liverpool care pathway. So this was a great idea. Hospice care is wonderful, okay? People get great end-of-life care in a hospice. Why can't we do exactly the same thing in a hospital? Well, you can, but you have to do it properly. And the trouble with the Liverpool care pathway is the Liverpool care pathway was different in every different hospital that you went in. There was no standardization in terms of what it involved, the training, et cetera, et cetera. And it came back to bite us. And I'm going to talk a little bit about the Neuberger review in a little while. Okay, moving back to more recent times. So the Dean mentioned about us moving to Dublin in 2021. So in 2020, I was getting itchy feet. Okay, I've been working where I was for about 10 years. I was bored. I tried doing a bit of medical management, hated that. I did a bit of the medical politics. That was all right to a certain extent, but I just wasn't feeling it. And then all of a sudden, out of the blue, I got 2 offers to apply for jobs. Okay. One was the job in Dublin. And one was at a cancer centre in the north of England that should remain nameless, but it's Europe's biggest comprehensive cancer centre. And so I had this conundrum, okay? So I'd started off life as an academic at the University of Bristol, where I'd spent most of my time doing academic stuff. And 1 month in 3, I'd do a bit of clinical. And then I'd gone back to being essentially a full-time clinician doing the academic stuff around the side. And what did I want to do now? Did I want to carry on doing that? Did I want to move to the north of England, where if you think it rains a lot in Ireland, it rains even more there. And it is a bit grim up north, certain parts, although there are nice bits in Cheshire. And there was the lure of big private practice as well, okay? Or did I want to come to Dublin? Now, I'd only ever been to Dublin twice before in my life, before I applied for this job. And I couldn't come and look around at the time because of COVID restrictions. So the first time was in 2016, when I actually was asked to lecture at the Grand Round in Our Lady's Hospice. And in those days, it used to be face-to-face, and they flew me in. They wouldn't put me up in the Shelbourne, but I mean, and then when we came on a holiday in 2018, so it was just like, well, you know, this is a big potential move, you know, like Manchester is just up the road. Yeah, it's not great, and you know, it rains a lot, but like this is a guy going to a different country. So talk to the boss. So we had a bit of negotiation. Basically, she said, I'm not going to Manchester. And I'll come to Dublin if you get the job. Okay, but there's some conditions. Okay, first of all, I want a dog. Okay, and I want a new property ping. Okay, there were a few other conditions as well. But actually, it was a big move for us because Louise had her own academic career. And we had 2 kids at university. We had our parents there. And at the time, my dad wasn't very well and Louise's dad wasn't very well. So it was a big decision. And when we arrived, as the Dean has said, it was 3 days after Brexit. We illegally crossed the border because at that time the airport was shut and you couldn't fly into Dublin. So we had to fly into Belfast and get in a taxi and sneak over the border. Although we did have approval for that, but technically that was illegal. And then as the Dean said, we ended up in the Shell one, which was hard. Okay, but I wanted to come and I wanted to make a difference. And I know that sounds really corny. But I was happy to come back to academia, but as long as everything was in place. So this is the Education and Research Centre, okay, at Our Lady's Hospice. So this is where we're based, the academic department. Okay, so we get the pointer. So this is my office there. The team are based on a mezzanine level, which used to be the old library. But we are angling to get up to this nice top floor. I saw Karen sneak in. That's where the All Ireland Institute are at the moment. But yeah, that's the plan. And this is the team. Okay, so when I arrived, there were 3 PhD students who were located in the department, but I wasn't supervising them. They were being supervised by my predecessor and or other people. And so I inherited one research nurse. So now this is most of the team. So we have 5 PhD students. We have 4, I think now, MD students. We've got 3 research nurses. We've got a wonderful secretary. And 2 of our PhD students are actually clinical lecturers. So 1 for TCD, 1 for UCD. And one of our nurses is doing a master's. So we've built up from essentially not very much to a nice team. They're all very young, they're all very enthusiastic, they're all very bright. They're very productive. They're also very reproductive. So the reason why these 2 on the right, so this is Jenny and Neve. Jenny's definitely here. I think I saw Neve as well. Yes, Jenny's at the back waving. Is because they're on maternity leave. In fact, 3 out of our department are on maternity leave at the moment. So I'm getting slightly worried because, as you can see, there's only Craig and I who. Okay, I'm just worried we're going to lose some more members. But what I wanted to do is I wanted to do meaningful research. Okay, and there isn't a huge amount of funding in palliative care, but a lot of the funding that's out there actually goes towards research that will make no difference to anybody. Okay, we don't need, another study of unmet needs in a different group of patients. Okay, because we don't even know how to manage the big group of patients, our bread and butter. So this is the philosophy. Okay, what we're trying to do is clinically relevant studies, answer the important questions, do sequential studies, close the loop. And what I mean by that is, okay, we've done studies in the past, found something interesting, and then done nothing about it. And so a lot of the work that we're starting to do now is picking up from stuff that I did in my previous roles. Challenge the dogma, use new interventions. I had to put this in because I found it when I was researching. So this is my coming day card from Cecily Saunders. So by the time I was at St. Christopher's, Cecily was fairly elderly and was still coming in. She was the chairman of the hospice. And she would still do writing and something. And on your anniversary of starting at St. Christopher's, you would be summoned to see her and have a little chat about how it was going. And she would give you your coming day card. And so this is my first coming day, where she actually mentions about research. So I thought I had to put that in. So what research are we doing? So I'm going to skip through this because I've just checked on the time. So this is my big project at the moment. And actually, we're not doing it in Ireland. This is something that started when I was in the UK at the University of Surrey. There's been a big debate over many years about the use of fluids at the end of life. And there's been a big pushback from palliative care that fluids are not needed at the end of life. They just cause more harm than good. They medicalize death. They shouldn't be used. And that has been challenged by various people. And actually, nobody has ever done any research looking at giving fluids to hydrated patients at the end of life. There are 3 randomized controlled trials of giving fluids to dehydrated patients at the end of life. But those are all methodologically flawed because they never actually rehydrated the patients. So we managed to get some funding from Research for Patient Benefit and did a feasibility study where we showed it, because people said it couldn't be done, that we could do randomized controlled trial, cluster randomized controlled trial in this group of patients. And although it's not powered, this study, what we showed is there was an improvement in survival in the group that got fluids. Now, it's a very small amount. It's less than 2 days in this group. But for some people, that might be very important if you're waiting for a relative to come from wherever. So after that was published in 2018. After many attempts applying to various different charities, grant bodies, we got funding for the definitive study. So this is happening at the moment in the UK. I'm the chief investigator, and it started in October. We're going to recruit 1,600 patients. So far, we've recruited 224. And from 80 sites, these are mainly hospices. Most of these are research naive. So this is a very unique study in lots of different ways. And it'll answer the question one way or another. I have my views about what I think the benefits of fluids are, but I'll be happy to be proven wrong. And so as the Dean said, the other thing that we're really interested in is oral problems. I'm going to skip over the next few slides, but what I did want to highlight from these slides is that actually oral problems are really common in our group of patients. So about 80% of people have subjective sensation of dryness of the mouth. And actually 80% of them actually have salivary gland hyperfunction. So if you measure their salivary flow rates, they're abnormal. But what's really important in this group of patients is that they're unstimulated, their resting salivary flow rates are really low, but you can stimulate the salivary glands, unlike patients who've had radiotherapy or patients who had Sjogren's. And so I've been interested actually in dry mouth in particular from the days when I was doing clinical oncology. And we did a randomized controlled trial then, pilocarpine versus artificial saliva for patients who had radiotherapy, and showed that pilocarpine, not surprisingly, was much better. And the reason for that is that although normal saliva is 99% water, that other 1% is really important. And you can't reproduce that, however much you try. So, so for my master's, I did another randomized controlled trial looking at chewing gum versus artificial saliva. And people going, oh, you can't do that. Old people, because most of the patients we see are elderly, they're not going to chew gum. All of these people were teenagers when we did the study, were teenagers during the Second World War, around the Second World War, or teenagers in the early 50s and whatever. Chewing gum is what they did. Okay, now that they were respectable 60, 70-year-olds, they weren't chewing gum, but they'd done it in the past. And as an option to treat their dry mouth, they were quite happy to do it because they tried the artificial salivas and it didn't work. So for my master's, for my MD, what I was interested in was the relationship between saliva and fungal infections. So I have to put this picture up because this took me weeks to get this picture. All of the pictures I'm going to show you are in black and white because they're so old, and I couldn't find the color pictures. I wanted to, for my dissertation, to have a picture of some Candida albicans, down a microscope. This took me weeks and weeks because Candida won't grow in nice flat films. It just tends to grow in all different directions. I couldn't get a nice picture. I had to keep doing it. And what was also interested in was identifying the yeasts. So historically, most of the isolates were Candida albicans. Okay, when we looked at our group of patients, about half of them were non-albicans species. And we identified them in different ways, including PCR. I just wanted to show you that, I have done some proper science as well. And we also looked at antifungal drug resistance. Now, this is not the sophisticated way of doing it using e-tests. We did use the more sophisticated broth micro dilution techniques. But you can see here, okay, in this one, you can see the rim where there's not much growth. So most of these organisms, okay, are sensitive to fluconazole, but you can see there's odd colonies coming through. Okay, so this is a patient with resistant oral candidosis. And what I showed or reiterated is that a lot of our patients, maybe a third of inpatients, will have oral candidosis. Okay, and the biggest reason for that is that they've got a dry mouth, and the biggest reason for that is the medication that we give them. And if you treat them with fluconazole or whatever, okay, the lesions may disappear, but they will come back because the reason why they've got oral candidosis in the first place is because they've got a dry mouth. And the problem about giving repeated courses of antifungals, okay, is that you promote the development of resistant organisms. And it's a particular problem with non-albicans species. So we found that about 25% of all the isolates from the mouths of the patients we were looking after were resistant to fluconazole, and it was cross-resistant with other azoles. So what we became interested in is the use of saliva stimulants. So if a dry mouth is the thing that's driving the oral candidosis, and we can't just keep patients on fluconazole, keeping them repeated courses, can we treat the dry mouth? So this is a patient. Now, you can't see the nice pseudomembranous candidosis on her buccal mucosa. This is a woman who had carcinoma of the thyroid. This was taken about 10 days before she died. So she had a really dry mouth, coated tongue, really bad halitosis, and the whole of the inside of her mouth was covered with pseudomembranous candidosis. And her husband couldn't sit next to her because the smell was so bad from the coating on her tongue. This is her 48 hours later. And all we did was we gave her bethanyl chloride, which is a saliva stimulant. Okay, so she cleared the debris off the tongue and the lesions, which we didn't photograph. Unfortunately, the pseudomembranous candidosis disappeared as well. So this is what we want to carry on doing, is looking at, going back to what Mary Baines was saying to me is, why has this patient got this problem? Okay, it's no good just treating the symptom, treating the problem. You've got to treat the underlying issue. So we're doing lots of things about oral problems. And we really would love to collaborate with people in the dental school. Because we want to do some microbiology and we can't do microbiology, oral microbiology. Just a few other things that we're focusing on. Okay, remote monitoring. So we have a workforce problem, particularly in the community. Okay, we know that the results from trials about outcomes of the community are not brilliant. Okay, And so how can we improve that? Well, if we did remote monitoring, and not just of symptoms, but of signs, and the technology is there now, okay, we can monitor patients properly at home. But as well as the patients, we need to monitor the carers, okay, and carer stress. And so Jenny, when she comes back from maternity leave, is going to set this study up. So a real-time study where patients and their carers will have an iPad. They will complete these assessments. They will take their blood pressure and pulse, and that data will automatically be uploaded to a dashboard. Okay, so people can see in real time what symptoms and signs the patient's got. They can look at changes over time. And then you can see there's been a change in Mr. Smith. Okay, his blood pressure is dropping. His pulse is going up. His symptoms going up. He needs to be seen today. Okay, and Mrs. Smith, okay, who's obviously fine. Yes, she hasn't been seen by the home care team for a couple of weeks, but she's fine. She doesn't. So this means we can allocate resources more efficiently to the people that really need it and pick up people who are just developing things like chest infection. Okay, get in there quickly, treat them because they become really symptomatic and need to end up in hospital. The other big thing, and I'll be finishing soon, that we're interested in is circadian rhythm disorders. Okay. What we know is that our patients, their normal circadian rhythms, and particularly their rest activity circadian rhythms, are altered. So for most of us, we spend most of our time in bed, lying there very still, not moving. And when we're up, that's when we do most of our movement. And there's this thing called the dichotomy index, which is the ratio of in bed versus out of bed movement. And in normal people, it should be about 98%. So 98% of your movement should be out of bed. Okay, so the person at the top is normal. Okay, so the gray periods are bedtime. The person at the bottom, you can see that their activity is all over the place. What we know from data is that people who have this altered circadian rhythm have worse symptoms, they have worse quality of life, and they have worse survival. Now, we think it's the cancer that's triggering this and or the cancer treatments, but the question is, can we retrain those circadian rhythms? And so Craig's PhD, amongst other things, is looking at, can we use a multimodal intervention to try and reverse that using light therapy, CBTI, and exercise. And we've got a load of other studies, and if anybody wants to collaborate with us, then please do. We've got some really interesting stuff with Geraldine Foley and Amanda Lavin and Roman in the geriatric department. So I'm going to finish now, and I want to finish with just some acknowledgements. So I don't know whether anybody recognizes who this is. Anybody from the dental school recognize this? This is Professor Jeremy Bagg, who was the Dean of the dental school in Glasgow. I think he's now retired. And actually the person who's pulling his mouth is Patrina Sweeney, who's senior lecturer in special care dentistry in the Glasgow Dental School. So Patrina and Jeremy and I have done a lot of work over the years. And these are pictures from a book that I wrote. Patrina wrote a chapter on oral health, and she managed to rope in Jeremy to be the patient. And I have been really lucky to collaborate with some really great people over the years. I want to pay particular thanks to Mel Waghorn, who's the current lead nurse on the Chelsea study. Mel's been my research nurse for donkey's years. And also Professor David Baton from King's Dental School, who's my supervisor for my MD, and his postdoc, Sue Brailsford, who taught me how to not set fire to the lab, amongst other things. And then there's a whole list of other people, and it's not supposed to be exclusive list, but these are people who were particularly helpful to me, particularly when I came to Ireland. And those first few months were quite tough. And particularly people like Roman, who actually out of the blue just reached out to me no reason why he should, Professor of gerontology, why would he? But he did, and he did everything he could to help me settle in. And then these people, really important people. So my parents, my mother, who, I mean, that's the reason why I came into medicine. She was a nurse. And my dad, who's my dad, my role model. And unfortunately, he never got to come to Ireland because he was too unwell to come. My sister, who's a fantastic sister, a fantastic aunt. She's a much better sister than I am a brother. And when I was having my bad times, she was always there for me. The other person is my father-in-law, who again was a great role model. Unfortunately, he's no longer with us either. But again, when Louise and myself were setting off together in our life, he was there to help us when we really needed help. The lovely Louise, okay, my best friend, I'm not crying, eh? It's my daughter, my best friend, and yeah, as I say, behind every man is a good woman. Well, she's a really good woman. My kids, this is them when they were a little bit younger. Yeah, they're amazing. I'm really proud of them. I don't tell them that often enough, but I am. And my adopted Irish child. Okay, my therapy dog. So I'm going to finish off now. So I'm going to show you this slide. And I have to disagree, actually, with Dr. Emmett Brown. I mean, if you're going to build a time machine and you're going to put it in a car, then put it in something classy. And if I did have a time machine, okay, I'd go back to the 19th of May, 2012. And I'd go to the Allianz Arena in Munich. And it'd be about 10:30 at night. And this is the first time Chelsea won the Champions League. But thank you very much. I apologize that I've gone over. And I hope I haven't wittered too much. But I just want to say, particularly to my team, okay, that you can do whatever you want. Okay, the world is your oyster. You're all bright cookies. Okay, and just make the most of it. Okay, as Emmett says, okay, your future is whatever you make it, so make it a good one. Thank you very much.